Hi everyone, and welcome to this part 2 lecture on epilepsy surgical techniques. So, in this lecture, we're going to be covering hemispheric disconnection, radiosurgery for epilepsy, LITT, and electrical stimulation for epilepsy. In the previous lecture, we've already covered resection procedures and palliative procedures. So, getting into it, the first section is on hemispheric disconnection. So, hemispheric disconnection obviously means that the entire hemisphere is disconnected from the opposite hemisphere. Now, if you just remove that hemisphere, obviously the function is served. So that was what was the first surgery that was done. And it was a hemispherectomy done in 1928 by Dandy and was first done for a glioma. But why are hemispherectomies, removing the entire hemisphere, not done anymore? Because there's a high rate of complications. Nothing happens immediately, but long term, there's a lot of problems. So the most important one is superficial cerebral hemosiderosis, and this happens because there's such a large cavity that there is actually multiple episodes of small bleeds which happen into this, and this leads to iron deposition onto the rest of the brain, and that impairs its function. Other things which can happen because of this bleeding and other problems is occlusion of the foramen of Monro and the aqueduct, which can lead to hydrocephalus. And there was a significantly high rate of death associated with hemispherectomies. And that is why we do not remove the entire hemisphere anymore. So instead, we are moving from more resection to more disconnection. And the first step towards this was a functional hemispherectomy. So there is a resection which happens in a functional hemispherectomy, but it is a large step towards more disconnection. So a lot of tissue around the insula is resected, as we will see going forward, including the basal ganglia and the temporal lobe, but everything else is just disconnected. We just disconnect the frontal, parietal, and occipital lobes when we do not resect them. So the advantages of this were that there were lower rates of the complications associated with hemispherectomy, so we did not see as much hydrocephalus and hemosiderosis. The overall complications decreased from 35 to 7%, and we still had a good amount of seizure control. It was 83% with functional hemispherectomies versus 85% with anatomical hemispherectomies. So these hemispherectomies are usually done for obviously hemispheric epilepsies. There is no reason to do a hemispheric disconnection for an epilepsy localized to a single lobe, okay, or maybe even two or three lobes. The epilepsy should be arising more or less from the hemisphere. The entire hemisphere should be involved. And if the entire hemisphere is involved, is usually a condition which has arisen at the time of birth. So it's either an inborn condition or a perinatal condition. There are a few conditions which can be acquired later on in life. So the most common etiology is that you would come across where a hemispherectomy or hemispherotomy would be done is conditions like Sturge-Weber syndrome or some developmental defects that you might encounter, like multi-lobar dysplasias, this case of hemimegalencephaly, but the entire hemisphere is just enlarged. There might be some intrauterine or perinatal ischemic insult or hemorrhages, some syndromes like the hemiplegia, hemiconvulsion epilepsy syndrome, and a condition which affects the entire hemisphere, causing it to atrophy and causing hemispheric epilepsy, that is Rasmussen encephalitis. Now, the indications for hemispherotomy, as we just mentioned, were patients who have these conditions. They have a unihemispheric lesion, which means it is involving only one hemisphere and does not involve the other hemisphere. And they have drug refractory epilepsy. So that's the best indication for a hemispherotomy. Now, you would think that can we possibly live with disconnecting a whole hemisphere? It is important to remember that this hemisphere is already not functioning very well in these patients. They already have a congenital insult or the hemisphere is already significantly damaged. So most of it is because of perinatal insult. So a lot of these centers which should be in that hemisphere have already shifted. They have reorganized and they have moved to the opposite side. A lot of these patients already will have spastic hemiparesis of the opposite limbs. So usually what happens after surgery is because of the disconnection, there is some loss of fine motor control of hand and a little bit of deterioration of gait, but usually patients within 2 or 3 months will be able to walk. Now, there are times when in hemispheric epilepsies, we should not consider a hemispheric disconnection. When it is clear you have done your evaluation and are not able to localize to a single hemisphere, then you should not do a hemispheric disconnection, because even after disconnection, epilepsy will continue to arise from the other side. That is where your palliative procedures might be more useful. Another relative contraindication would be where there's a different independent seizure which is arising from the contralateral hemisphere. This will be able, so if you do a hemispherotomy here, it will be able to take care of the primary seizure arising from that ipsilateral hemisphere, but the patient will continue to have other seizures arising from the other hemisphere. Right, so the standard evaluation you would do for hemispherotomy, including an MRI, a video EEG, and a neuropsychological assessment for all patients before they're even considered for surgery. An important test you might want to consider in these patients would be VADA testing, because you want to know if language actually has shifted to the opposite side or not. So the goals of such a major surgery is that if you are doing the surgery, the seizures should stop. So there should be a high chance that the seizures will stop. And another very important thing is that there should be a relief of epileptic encephalopathy. Now, with drug refractory epilepsy and such congenital causes, and because of the long-standing nature of the disease, these multiple seizures end up causing a phenomenon known as epileptic encephalopathy. The entire opposite hemisphere also, basically the entire brain gets affected, and there are significant neurological and psychiatric disturbances which develop over time in these patients. Okay, and that is what is known as epileptic encephalopathy. So once you stop these seizures, either by medicine or in drug refractory cases with surgery, this epileptic encephalopathy should resolve and the patient's psychiatric and neurologic condition should improve. So that's another goal of surgery in these patients. Right? So once we stop that, there should be some improvement in cognitive development and behavioral disturbances. But the main goal of surgery is that seizures should stop. Some of the side effects of hemispherectomies or hemispherotomies are unavoidable because you are disconnecting a whole hemisphere. So it is expected that there will be a complete hemianopia and there will be loss of fine motor movement of hand and foot. But only in a few patients do you get deterioration of gait. And if language has not completely shifted to the other side, which it usually would have, especially if it's a perinatal condition, if it has not shifted, there's a chance you can get aphasia. Okay. Now coming to how to do a hemispherotomy or a hemispherectomy itself. Okay, so there are at least 5 types of hemispherectomies we should know about, and these are all depicted here. So this first type is just an anatomical hemispherectomy, which is basically removal of the entire hemisphere. You can see that entire hemisphere has been removed. Now, a very commonly done hemispherectomy is what is known as a functional hemispherectomy. In a functional hemispherectomy, you can see that there is a significant amount of resection which has happened. But some of this tissue on the same side is still left behind, but it has been disconnected. So that is a functional hemispherectomy. As we go on, less and less tissue is resected, and it's more and more about disconnection. So in a peri-insular hemispherectomy, you can see the tissue of the insula and around it has been resected, and there's a disconnection which happens above the insula and below the insula, and that's all. But a significant amount of tissue has been preserved, but it is just disconnected. In a trans-sylvian hemispherectomy, there's absolutely no resection and it's only disconnection. This can similarly be done from the parasagittal route, and that is what is known as a vertical hemispherectomy. Now, there are multiple different incisions which have been used to do a hemispherectomy, and it depends on the type of hemispherectomy you want to do. Usually for like a anatomical or a functional hemispherectomy, require a significantly large exposure. So you would do either a question mark incision or a T-shaped incision. If you're just doing a trans-sylvian hemispherectomy or even a peri-insular one, you can take much smaller incisions. For a vertical hemispherectomy, you can even do a small linear incision in the parasagittal region. Excuse me. Right. So coming to the different hemispherectomies. So first we'll discuss a functional hemispherectomy. Okay, a commonly done hemispherectomy. So here what we do is we just the surgery itself is quite standard, and like the positioning and incisions are quite simple. So the patient is positioned supine, the head will be on pins, and the head will be turned such as the zygoma is the most elevated point, as you would do for a standard penile craniotomy. The incision, one of the only times that you would actually use a T-shaped incision is for a hemispherectomy. Okay, so one the commonly used incision is the T-shaped incision because you get a quite good and wide exposure with this. You can even use a reverse question mark incision and other incisions as comfortable. Now, the key steps of a functional hemispherectomy is that you go in first and do an ATL and H. You go in, you remove the temporal lobe, you remove the amygdala and the hippocampus. Following that, you go in and you have to remove the central core, okay, or the central cortex, okay, and the parietal tissue with all the way down to the corpus callosum over here. Following which a callosotomy is done. So the callosum is divided from all the way anterior to all the way posterior. From up till the anterior commissure here, all the way posterior to the splenium, the callosum has to be divided. Okay, if any fibers are left behind, the disconnection will be incomplete and the patient can continue to have seizures. And finally, the insular cortex, as you can see here, has been resected. So these are key steps of a functional hemispherectomy. There is a significant amount of resection which happens here, but some of it is left behind the tissue, and then that has to be disconnected. So the callosum, importantly, has to be disconnected throughout its length. Okay, so the next is a much more disconnective procedure where there's absolutely no resection. This is done through a small keyhole approach only, a small 4 into 4 centimeter craniotomy done just superior to the Sylvian fissure. So this is a trans-Sylvian keyhole technique. You make a small opening right above the Sylvian fissure and go in through the Sylvian fissure and expose the entire insula. Okay, so here there are 4 main steps. You go in, expose the circular sulcus, the superior aspect and the inferior aspect, following which there is a temporomesial disconnection. As you can see this line over here, that is the second step. You'll enter through the circular sulcus and then disconnect this temporal stem. Okay, so the entire, that is from all the way from the front to the back, so the entire mesial temporal lobe will be disconnected, and this has to be carried all the way back up till the trigone at least. Following which, there are 2 steps which need to be done. There has to be a lateral disconnection over here, and then there has to be a mesial disconnection over here. So the lateral disconnection is from this Sylvian fissure all the way to reach up to the ventricle. Okay. Following which, once you enter the ventricle, you can do a mesial disconnection and disconnect the corpus callosum. Okay, so basically through the Sylvian fissure, the entire length of the lateral ventricle will be open from the front till the back. So that is a lateral disconnection. Once you have opened the ventricle and gotten inside, you can disconnect the corpus callosum through the ventricle. So that is a callosotomy. You can also go anteriorly and posteriorly and disconnect the frontal and the parietal white matter up till the point of the fox. So this is particularly useful for patients who do not have a significantly large hemisphere. So in patients who have hemimegalencephaly, this would not be possible because they need some resection. There needs to be some space. So it is very good for patients who have a lot of atrophy or porencephalic cysts. But the bigger the hemisphere, the more resection you need to perform. There's another completely disconnective technique which can be done through a vertical pachygetal incision, and that is known as a vertical pachygetal hemispherotomy. So again, this is less resection and more disconnection. It's also called a dorsal transcortical subinsular hemispherotomy because it is done from the dorsal approach and it is all below the level of the insula. So as you can see here, this is the vertical hemispherotomy, and you're going to be entering from above and creating disconnection lines, as we can see along these dotted lines here. So we'll see how this happens. So there are basically 5 steps to a hemispheric deafferentation. And the way that it is done in a vertical parietal hemispherotomy is as follows. So first you create a parietal frontal craniotomy. Okay, it's right next to the midline. It is 3 into 5 centimeter in size, and it is about 1/3 anterior and 2/3 behind the coronal suture. Following which, this cortex overlying the lateral ventricle has to be resected. As you can see here, this cortex will be resected so you can enter the lateral ventricle over here. So as you can see here, this is the ependyma of the lateral ventricle, and this has to be entered. Following which, medially here, you would be able to find the corpus callosum. And then that has to be disconnected. So there is a paramedian callosotomy which is done. So you have to disconnect and go posteriorly all the way to the posterior column of the fornix and disconnect that also. Okay, so you have done a callosotomy now. Now the main disconnection left here after you've done a callosotomy is to go in and disconnect all the tissue which is lateral to the thalamus. So there's a lateral transaction which is done between the thalamus and the striatum. So basically you'll go around the thalamus, following the curve of the ventricle all the way around from this body of the lateral ventricle and go down all the way into the temporal horn, just curving around the thalamus. Okay. After that, you would go back anteriorly. Okay. So as you can see here, this is the lateral disconnection line curving around the thalamus and going posteriorly into the atrium, and then it would go down into the temporal horn. After that, you also have to do an anterior disconnection. So you would follow in front of the anterior part of the corpus callosum and resect this gyrus rectus. And after resection of the gyrus rectus, you will wrap around the choriate lobe and then join this disconnection line over here to the lateral disconnection line over here. Okay. So just to discuss it again, you do a passage of frontal craniotomy, resect this cortex to enter the lateral ventricle. Once you've entered the lateral ventricle, the first step is to do a callosotomy over here. After a callosotomy, you would do a lateral transaction. You will disconnect laterally around the thalamus, following all the way around the body, the atrium, and the temporal horn. Okay, so disconnect all the tissue which is in the parietal, occipital, and temporal lobe. After that, you will come back anteriorly, disconnect part of the anterior callosum, and then remove the gyrus rectus and follow this back and connect with the transaction line which is lateral to the thalamus. Okay, so the next technique is a peri-insular hemispherectomy. So here, this is a combined resection and deafferentation technique. So in this technique, there's a moderate resection of the brain tissue and there is disconnection along with that. So as we can see over here, we go in, open the sylvian fissure, resect part of the insula, go above the insula, there's a suprainsular window and there's an infrainsular window to cause these disconnections. So this is a combined resection with deafferentation, so the peri-insular hemispherectomy. As we have already discussed, there are some classic techniques which were followed previously, an anatomic hemispherectomy where the entire hemisphere is removed. And there's even a surgery called hemidecortication where the entire hemisphere's cortex is removed because it was assumed that seizures arise only from that cortex. So which is actually correct, but there are also seizure substrates which can lie deeper inside, as in the thalamus. So previously it was thought just removing the cortex should be sufficient, but these two surgeries are not done anymore. Okay, so with hemispherotomies or hemispherectomies, what are the outcomes that we should expect? Will a patient be completely seizure-free? So in recent series, it has found that the outcomes are quite good. At least there is a 75 to 90% seizure freedom rate in recent series, which is quite good. But for patients who have congenital problems, which are long-standing, the seizure rates are quite poor. So here, for hemimegalencephaly, the seizure-free rates are only 40 to 60%. For some of these conditions, though, seizure rates, freedom rates can be quite high. For Sturge-Weber syndrome, you can achieve up to 100% freedom. For Rasmussen encephalitis, it is up to 80%. And for porencephalic defects, it's actually 95%. Mostly patients who have a cortical dysplasia and hemimegalencephaly have poor outcomes with all the different types of surgery. It is not like a hemispherotomy has absolutely no complications. Obviously, it does have complications, but they are at least much lesser than you would expect with a hemispherectomy. So one of the most important complications that can happen is there can be an incomplete disconnection. Remember, it's not a resection, so there is some tissue which can be left behind, still connected to the opposite hemisphere. So this can happen in 2 to 30% of patients and lead to persistent seizures. Apart from that, the other complications are quite standard. You can get blood loss, electrolyte disturbances, coagulation disorders, etc., etc., because of prolonged surgery and other features of large and longer surgeries. Apart from that, because there's so much brain trauma involved, you can get DI, SIADH, transient rises in temperature, swelling of the contralateral hemisphere, and electrolyte disturbances. Apart from that, you can get subdural hygromas, you can get bone flap infections, and there is still a risk of hydrocephalus, but it is much lesser than you would expect with a hemispherectomy. Shunt rates in these patients are 8 to 30%. Now, hemispherectomies, or actually hemispherotomies, have become a lot more minimally invasive. So there are hemispherotomies which can be done with the assistance of an endoscope, but still primarily microsurgical. And there are hemispherotomies which can be done completely endoscopically also. So we'll just discuss an endoscopic assisted hemispherotomy. So in this, it is again a keyhole approach, okay, and it is done through a small craniotomy, so a mini craniotomy basically. And again, the approach is through an interhemispheric transcallosal approach. Okay, so here basically a small craniotomy is done just around the coronal suture. You have to make sure that bridging veins are not there. So here in this case, navigation would be quite important to rule that out. There are 4 cardinal steps as we will discuss next. The main issue with an endoscopic hemispherotomy is, as you can see here, if you enter from this region, trying to disconnect the temporal stem could be quite difficult. So that is the most difficult part in an endoscopic hemispherotomy, as it is the deepest tissue. Now, there are 4 cardinal steps once you enter with an endoscope in an endoscope assisted hemispherotomy. So, the first thing you would do after inserting the endoscope is identify the corpus callosum. Okay, remember you're going interhemispheric transcallosal. So, you're going to find the corpus callosum first and you're going to disconnect the entire length of the corpus callosum from all the way from the geno in the front to the splenium posteriorly. Once you have done that, you can go ahead in the front and do an anterior disconnection. How that is done is from the point at which you have disconnected in the geno of the corpus callosum, you go ahead and resect the gyrus rectus. After that, you just curve it around. Okay. And it is curved around the caudate lobe and carried posteriorly up till the sphenoid ridge. So that is your anterior disconnection. Following which there's a middle disconnection, which is basically just around the thalamus, again going into the atrium and the temporal horn. Following which there's a posterior disconnection at the level of the atrium where the hippocampal tail and the fornix are cut. So very simple 4 steps are there. Obviously, in practice, it's a lot more difficult, but just a corpus callosotomy, an anterior disconnection, a middle disconnection, and a posterior disconnection. Another commonly done disconnection I'd like to discuss is a posterior quadrant disconnection. This is usually done for for lesions not involving the entire hemisphere, but basically involving a large segment of the hemisphere, but not the frontal lobe. Remember, the frontal lobe occupies a huge portion of the hemisphere. Okay, so disconnections can be done just for the frontal lobe also, and disconnections can be done for the rest of the hemisphere, and that's called a posterior quadrant disconnection. Okay, it's also known as a temporoparieto-occipital disconnection. So in this image, you can see the lines to follow for a frontal disconnection. As you can see, it would be anterior to the motor cortex, and this is the line to follow for a posterior disconnection. It is posterior to the entire motor sensory strip. Okay, so these patients, the surgery is the positioning in the incision are quite straightforward. The patient is positioned supine on pins. You can take a T-shaped incision for good exposure. Other incisions are also feasible. Do a temporoparietal craniotomy. It is important to go all the way up to the coronal suture so the motor cortex is exposed. Once you identify the motor cortex and sensory cortex, you can go ahead and do a temporal lobectomy, remove the amygdala and the hippocampus, and from posterior part of your lobectomy, just go ahead and disconnect this entire segment over here. So you have to do a lateral disconnection and a medial disconnection. Okay, so lateral disconnection is from the cortex all the way down to the ventricle. From that ventricle onwards up till the fox medially and the tent inferiorly is the medial disconnection. Right. So that is about hemispheric disconnections and all the different types of those. I can understand that was slightly confusing. So going forward, these are all quite small sections, and we'll just cover the important aspects of what we should know about these other alternative techniques for treatment of epilepsy. So the first one we're going to discuss is radiosurgery for epilepsy, and it is a vastly growing field currently. So why radiosurgery? Why not just surgery? Okay, so with open surgery, it has been found that there's actually 5 to 23% risk of neurological deficits. Okay, so radiosurgery, we know that is becoming a massively important alternative for open surgery. Can it be used for epilepsy? Yes, it can. It is currently under investigation for mesial temporal lobe epilepsy, hypothalamic hamartomas, and epilepsy associated with vascular malformations. And it has been found to have quite good results actually. How does it work? We know with tumors, it works by destroying the tissue. Okay. But for epilepsy, there might actually be a different mechanism of neuromodulation. It has been found that SRS might actually induce a remodeling of the glial environment, and that might lead to modulating the activity and modulating the function without actually destroying the neural tissues. So, apart from destruction, there is another possibility of how it works, that is neuromodulation. Now, it has been found in studies, particularly in preclinical animal studies, that you require at least a dose of 25 gray for it to have a therapeutic anti-epileptic effect. Another very important thing to remember when it comes to radiosurgery for anything, the effect always takes time. The effect is going to take months to develop, and that is a major disadvantage with radiosurgery. That instead of having immediate effect as you would have with open surgery or some other techniques, radiosurgery takes time. Okay. Now, does radiosurgery work for mesial temporal lobe epilepsy? There was a multi-center prospective European study done which showed that there was actually 65% reduction of seizures using both microsurgery and SRS after 2 years follow-up. So they were comparable. A ROSE trial done, that was the International Radiosurgery or Open Surgery for Epilepsy trial, found that SRS gave 67% seizure freedom for at least 12 months. So this is actually quite comparable with the results of microsurgery. But even though it seems like, okay, it's a very good alternative, there are some problems. The beneficial effect takes time. It will not happen immediately. ATL-AH will give you results right then and there. But radiosurgery takes time. You will find a reduction in seizures happening only after 9 to 12 months, and a dramatic improvement will be seen only between 18 to 24 months. Apart from that, there's also a risk for delayed cerebral edema, as usually we do expect such things to happen with radiation. There will be, in quite a few cases, cerebral edema developing 10 to 15 months after treatment, and some of these patients do end up requiring steroids. Apart from that, radiosurgery cannot always be localized only to the area that you want it to be. So as we know, for specifically for MTLE, there is a risk of optic nerves, optic tract all being quite close to the area of radiation. So there is a significantly high risk of visual field deficits, but still not as high as you would expect from an ATL. ATL at least has a 90% risk of visual field deficits, but radiosurgery still has a 62.5% risk of visual field deficits. But there are clear-cut benefits. It is non-invasive, there's a shorter hospital stay, and you can immediately go back to work. And as compared to open surgery, there is a higher chance to preserve memory. Okay, it has been found that at least 20 gray is required for anti-epileptic effect in MTLE. The target, as you would expect, is just the amygdala and the hippocampus. Okay, but a big problem with SRS being applied to MTLE is that in some of these cases, the seizure focus is not always just the amygdala and the hippocampus. And sometimes defining the exact location of the epileptogenic zone can be quite difficult. So that is where it can be a little difficult to apply SRS to MTLE. Now, particularly for mesial temporal sclerosis, it has been found that the mechanism is not just neuromodulation. It requires a necrotic effect. There has to be some destruction which has to happen for there to be an anti-epileptic effect. So most likely it's both a combination of tissue destruction and neuromodulation. Okay, so currently, when would we consider radiosurgery instead of open surgery? We know that open surgery is the standard for MTS, but there are some cases where you can consider radiosurgery instead. So when it is very clear that the EZ is located just in the amygdala and the hippocampus, you can consider only radiosurgery. Another would be if already patient has underwent ATLAH, there is an insufficient recession, some tissue is still left behind, that can be targeted with radiosurgery. It is also a good option for patients who have involvement of the eloquent cortex, or they have some very deep-seated epileptogenic zones. So these can be targeted with radiosurgery instead of open surgery. Another very commonly treated problem with radiosurgery is hypothalamic hematomas. Now, hypothalamic hematomas are congenital heterotropic lesions, and if they get attached to the Papez circuit, specifically the mammillary bodies, they can become epileptogenic. Classically, hypothalamic hematomas will present with gelastic seizures. That's where the child will laugh in the first year of life. Okay. Now, the thing is, because these start quite early, in a still developing brain, there can be a large amount of complications which develop because of these seizures. So, with severe long-standing disease, they quite early on develop epileptic encephalopathy. The epilepsy becomes drug resistant. They develop multiple seizure types. They easily generalize. They develop drop attacks, have cognitive decline, and severe psychiatric problems. Particularly, hypothalamic hamartomas with epilepsy, even without epileptic encephalopathy, are usually drug resistant right from the onset. So, making surgery a very important option in these patients. Apart from seizures, they can also present with precocious puberty and neurological disorders even without seizures. Okay, so surgery is one of the main treatment options for hypothalamic hamartomas. Okay, now resection itself can just cure epilepsy, and it is important to do treatment as early as possible because the longer we wait, the more the problems arising from long-standing seizures. Okay, now it is important to remember that hypothalamic hamatomas are located in areas which are very difficult to access and have a lot of elopement structures around them, making them very risky to approach. So they're usually broadly attached to tuber cinereum or mammillary body, and that is usually when you get epilepsy, and you can just imagine how difficult that would be to go and surgically resect. So there are high risks of microsurgery in this area. You can damage the vessels and have hemiplegia. You can have third nerve paresis. You can have diabetes insipidus. You can have hyperphagia. But if you do go ahead and resect them, seizure control is excellent. It is possible now to be less aggressive than to do open surgery. Just disconnecting the hypothalamic hamartoma is enough to stop seizures. There's no need to gross totally resect the hamartoma. Just go ahead and just cut it into half. That itself can be sometimes enough to stop seizures, or you have to disconnect it from the mammillary bodies or the Papez circuit. Apart from that, even minimally invasive approaches, SRS, RF ablation, and LITT have shown very good results for hypothalamic hamartomas. So, a very commonly used technique now is radiosurgery for hypothalamic hamartomas. Now, it is important to remember that these are near structures which are very fragile. So, there is the optic apparatus right there, and there's a hypothalamus right there. So dose planning for a hypothalamic hamartoma can be quite complex. The peripheral doses should be kept low. So usually the median dose to a hypothalamic hamartoma is 17 gray. We cannot go as high as 20 and 25 gray. With this, angle class 1 to 2 has been achieved in 75% of hypothalamic hamartomas of types 1 to 3. So we'll see what are these types in the next slide. But 75% angle class 1 to 2 outcome is quite decent for a surgery where we are avoiding open surgery. And it was found that with this, there were actually no permanent neurological deficits, and there were dramatic improvements in behavior and cognition and strong psychiatric benefits. So it seemed like a very good option. So SRS is actually a good first-line therapy for small to middle-sized hypothalamic hamartomas. So there are different types of hypothalamic hamartomas, and they classify according to the structures that they involve. Type 1 is a small hypothalamic hamartoma located inside the hypothalamus, and it is extending into the third ventricle. So you can imagine the surgical risk associated with this. They are usually poor candidates for microsurgery, and radiosurgery is preferred here. Type 2 are small lesions within the ventricle. Again, even though it is easier to do microsurgery, radiosurgery is still a safer option and preferred. Microsurgery can be done through a transventricular approach, either microsurgery or endoscopic surgery. Type 3s are located in the floor of the third ventricle. Again, because they're close to the mammillary bodies and fornix, radiosurgery is preferred here. Type 4 is here located in the cistern outside the third ventricle. So here, it is actually easy to go ahead, go into arterial craniotomy and just disconnect it there. But if it is quite small, then gamma knife or radiosurgery can be considered. Type 5 is pedunculated in the cistern, and it is actually rarely epileptic because it's not connected to the mammillary body usually. And if it is causing problems, it can be removed with microsurgery. Type 6 are giant hypothalamic hamartomas, and because they involve so many different structures, they're not good candidates for either SRS or open surgery, and they usually require some combined modalities where you would go in and resect as much as possible, followed by radiosurgery to whatever is left. SRS has been used even for vascular malformations with epilepsy, such as AVMs and cavernous malformations. Now, SRS is applied to cavernous malformations for two reasons. It has been considered even for preventing future hemorrhages, but also to reduce seizures. Now, with trying to prevent further hemorrhages, the role of SR is actually controversial in cavernous malformations, but currently evidence is growing in favor of SRS. A study has found that using SRS in cavernomas decreased rebleeding rate from 32% per patient year to 8.8% in the first year and 1.1% in the second year. So it actually has a good role for particularly deep-seated and eloquent lesions. For patients who do not have such lesions, if they have lesions which are cortical and subcortical and not located in the eloquent regions, then microsurgery is definitely the treatment of choice. But for patients who have deep-seated lesions, eloquent cortical lesions, SR is actually a good option for both prevention of future hemorrhages and for controlling seizures. A study found that there was a 53% Engel class 1 outcome with SRS for controlling seizures and cavernomas. Okay, so radiosurgery can even be used to target the corpus callosum and do a callosotomy. So an entire callosotomy can be done with just radiosurgery. So it's found that 2/3 of patients who underwent an SRS callosotomy had significant improvement and they had no major neurological complications. The doses for a callosotomy have to be much higher because we are focusing on destroying tissues. Here, the concept is not neuromodulation. We have to destroy the entire corpus callosum. The doses are 55 to 85 grays. Okay, so that finishes the topic of radiosurgery for epilepsy. Now we'll discuss a concept which has come up in the last few decades, that is LITT. Okay, so what is it? So LITT stands for laser interstitial thermal therapy. Okay, so I think all of us know how a laser works, and basically it creates, amplifies, and emits a beam of light. Now, in 1983, a laser was used for external therapy. And basically, what they did was they put the laser tip outside the tissue and tried to heat it up and destroy the tissue. The problem was because you're holding the laser tip outside the tissue, the laser tip heats up very quickly and it can actually be destroyed because of this. So then they came up with an idea to put the laser tip inside the tissue, because of which now that tissue itself can dissipate the heat and then the laser tip will not heat up as much. So that is what is basically interstitial therapy, that the tip is placed inside the tissue. This allows the tissue to reach a higher temperature because you can heat up the laser tip now to a lot higher temperatures. And the energy that is generated now is distributed roughly spherically. And this energy can be visualized with an MRI, and that is what is known as MR guided LITT. This MR is able to guide and monitor LITT in real time. Okay, so in 2012, that was the first report of using MR guided LITT in epilepsy. So this year is the LITT probe, which has been inserted into the amygdala and hippocampus for a patient with MTLE. Okay, there are also other minimally invasive options which can be done similarly with thermocoagulation, RF lesioning, and SRS. Okay, SRS is not even a invasive option, it's basically non-invasive. But as compared to RF lesioning, MR guided LITT is a lot better because of the MRI, it gives you real-time feedback as to how much heat and how much destruction is happening. And sometimes the radio frequency source can be imprecise. So MR guided LITT is definitely better than RF lesioning. It has been used for quite a few conditions in epilepsy. It has been used for mesial temporal lobe epilepsy. Basically, the probe is inserted via an occipital approach and you insert it along the entire long axis of the hippocampus. You enter the amygdala and start heating the tissue up. And then, using real-time feedback, keep withdrawing the catheter and burning the hippocampus along its long axis. It has been found that for MTLE, the 12-month Engel class 1 outcome is 40 to 60%. But that is usually because the entire hippocampus would not have been ablated. So usually these patients can undergo a repeat ablation, and following which seizure control can be achieved in up to 70%, which is quite comparable to surgery. An important thing to note is that compared to surgery, there is a better neurocognitive profile and there is a lower risk of visual field deficit. Remember, open surgery had a 90% risk of visual field deficit. In LITT, there's a lower risk of only 37.5% of visual field deficit. It is very clear that LITT will not give you as good seizure control as open surgery will. it is a lower rate of seizure control, but it is at the benefit of a risk of lesser complications. Apart from MTLE, it can also be used for other conditions like FCD, and it has been found that seizure freedom rates for FCD actually reach from 50 to 100%, while for surgical resection, they're around 60%. It is still currently evolving, but it is good for some few types of patients. Patients who are at high surgical risk, particularly for deep-seated FCDs for eloquent regional lesions, where you would not want to approach through open surgery. It is also good for a particular type of dysplasia known as bottom of the sulcus dysplasia. It is also a good option for other eloquent regions like insular epilepsy. It has been found that there's a comparable rate of seizure freedom with surgery and LITT. It is slightly less effective, but as we have discussed already, complication rates are much better with LITT as compared to surgery. As we saw, it is also a minimally invasive option for hypothalamic hematomas, and LITT is actually a very, very good option for hypothalamic hematomas. A last study found a 97% seizure freedom rate at 1 year follow-up with LITT. So actually, current evidence suggests that LITT is a much safer and more effective approach than traditional surgery for hypothalamic hematomas particularly. So this is the one case where we have demonstrated clearly that LITT is a much better and safer approach and actually more effective than open surgery. It can also be used for cavernous malformations and for corpus callosotomies as well. Okay, so that brings us to the last section for the talk, that is electrical stimulation for epilepsy. Okay, now how does electrical stimulation work and what is it exactly? So the basic concept here is that there are networks in epilepsy, similar to networks that we will discuss when we discuss functional neurosurgery. There are networks along which epilepsy propagates and originates. So the focal seizures particularly appear to propagate along some common neural circuits. There are two important circuits. There's a cortical striatal thalamic network and there's a limbic circuit of Papez. Okay, so these are very well-known circuits. And it's been found that either destroying substrates in these circuits or using high frequency stimulation in these regions in particular areas can actually have an anti-epileptic effect. The most commonly targeted areas would be the hippocampus, the mammillary bodies, the subiculum, and the anterior nucleus of the thalamus. Okay, another important structure you can note here is the vagus nerve. Now, how does this work? The vagus nerve sends sensory afferents to the solitary nucleus, and the solitary nucleus sends afferents to the locus coeruleus, following which the locus coeruleus has a widespread network, which again goes and supplies similar structures as we can see in these two networks. So that is how vagus nerve stimulation works. Now, overall, how does neuromodulation work? The exact mechanism is still not clear. Most likely it is complex and we just don't know all the different facets involved. What has been found is that once you put an electrode into a tissue, whatever tissue is within 2 millimeters of the electrode will work and will produce an output at this frequency that you're stimulating at. Now, whatever is a cell outside of the 2 millimeters, that will be stimulated only at a subthreshold level, and because of that, it will be blocked, it will be suppressed. So there is a chance that how stimulation works is that it blocks and replaces all the abnormal neural activity which is arising from around the electrode and actually stimulates normal activity. But still, the exact mechanism continues to remain very unclear. Now, there are three important electrical stimulation paradigms we're going to discuss. The first one is vagus nerve stimulation. Now, how does this work is we put coiled electrodes around the left vagus nerve. Okay, we do not use the right vagus nerve because that can lead to some cardiac problems. So we use the left vagus nerve, and these electrodes are then connected to a generator which is placed in a subcutaneous pocket in the chest. Now, it has been found that vagus nerve stimulation is actually able to reduce seizures by around 50%. The longer it is used, there is a slightly more reduction in seizures, but it is not without complications. There are some problems which can happen with vagus nerve stimulation. Okay, but still, it is a very good option. There are some voice changes and hoarseness, throat pain, coughing, and dyspnea which can develop, but For a patient who has long-standing epilepsy and is unable to undergo resective or disconnective surgery, vagus nerve stimulation is quite a good option to achieve a reduction in seizures. Okay, it's basically considered currently an adjunctive treatment for children who have partial or generalized epilepsy. It's also a good option for those with Lennox-Gastaut syndrome. Okay. Apart from that, another technique which can be used is DBS, and there are multiple different targets that have been tried in patients with epilepsy for DBS. The first target that was used was cerebellum. It was the earliest target and actually achieved a decent reduction in seizures of 76%. But multiple studies that were done have found that the complication rates are quite high. And the 76% seizure reduction might not actually be accurate. So its usefulness was actually questioned, and we do not use the cerebellum anymore for this purpose. Apart from this, there are other targets. The most commonly used one for DBS is the hippocampus, but there have been some mixed results. But recent trials have shown that for patients who cannot undergo resection or ablation, DBS of the hippocampus is a good option. There are a few other targets which can be used, like STN DBS for myoclonic epilepsy, the central median nucleus of the thalamus for generalized epilepsy, the anterior nucleus of the thalamus, and the nucleus accumbens. There's also another important concept which is there out in the market right now, that is responsive neurostimulation. Responsive neurostimulation, the basic idea here is that there is a device which is implanted, quite a large device, as we can see over here. Okay, a huge, like basically a large skin flap is raised, a huge hole is made into the skull, and then this device is implanted in there. Okay, so it's a biosensor. What it does is basically it picks up electrical activity and then stimulates the cortex as a direct cortical stimulation, which is able to stop this activity. So that is how responsive neurostimulation works. It was the first study using this was published in 2011. And as we've discussed, it is a closed loop system which can pick up seizure activity and then stimulate the cortex to stop it. So what you do to do this RNS is basically find the epileptogenic zone using intracranial monitoring, put electrodes in the region which are causing seizures, and then these electrodes will be able to pick up the seizure activity and stop it. So as we can imagine, there's a huge advantage to this in the ability to record electrical activity from these patients in a non-lab setting over a long term as well. Now, does it work? So the RCT, which was published in 2011, found that actually there was a 41% reduction in seizure at 5 months, and as we go on with time, the seizure reduction rates increase. Overall, with RNS, you can expect that more than 50% of patients will experience at least a 50% reduction in seizures over the long term. But it is very clear that no patient will achieve complete seizure freedom. Seizures will reduce significantly, but seizure freedom will not occur. So RNS is particularly used for patients where you are not able to do the classic standard surgeries. So those who have multiple onset zones, patients who are not candidates for resective surgery, patients who are at high risk for surgery, have epileptogenic areas in eloquent cortex. So that's where RNS becomes a very good option. Now, there are very low complication rates with RNS, which makes it such a good option. And these are usually implant site infections, lead replacements, intracranial hemorrhages, and they've been found to be not very significant. The only thing is that long-term studies are still required to evaluate efficacy and safety profile. Right, so that is all for today's lecture, and thank you so much for attending. If there are any doubts, you can enter them in the feedback form provided below.